Dr. Harshul is the chief eye surgeon at Rawat Eye Hospital, Rajasthan, and is besides the fact that we know his surgical prowess is par excellence, and he makes probably one of the best videos in our country. But what is also important is he's the chairman scientific committee of the very awe-inspiring Jaipur Ophthalmic Society, and we look forward to seeing how well it's going to flourish under his tenure. So on to you. He is going to be talking on extending and extended rexis, how best we would handle.
Thank you so much for giving me this opportunity, and I'm very sorry for some technical glitch there. So I'll be talking about how to rescue the extending rexis and what to do if it is extended. So this is the case where its rexis is, I'm making the cystotome and it's going routinely. But as I reach in this place, if you see the direction of the rexis is going outwards now. So at this point, we need to stop there and we need to go and put some OVD in front of the leading edge. And then we need to pull this rexis in the center. If you look at the direction of the pull of the rexis forceps, it's towards center. And the rexis is coming back on the right track. So this is a maneuver which every young surgeon or any surgeon should know and should use in the case where your rexis is trying to go outwards. Another case where it's a mid-dilated pupil, rexis again is going outwards and it's going behind the iris margin. I'm trying to get the rexis on the right track, but it's sliding downwards. So now here I can't see the leading edge. So if you can't see the leading edge, don't go and do blindly. Because of the site of the rexis where it is extending, I'm not able to use my Q-glance hook or any ball tip dialer to retract the iris because this is the left side. So what I'm doing here is making one side port incision and using iris hook there and going in front of the leading edge so that I don't tear the leading edge, again putting OVD there. And once you place the iris hook there, you can now visualize where the leading edge of the rexis is. So this little time which you are spending here, it's worth it. You can save the rexis from this place. So here now I can see the leading edge here, and again pulling it toward the center and getting it on the right path. So you can see the rexis is coming on the right path here again. So this is a little trick which you can use if it's a mid-dilated pupil and you're not able to visualize the rexis margin. Another case where I'm using a cystotome here, reaching to the subincisional area, I go ahead and put OVD there. And using a rexis forceps here, but look at the direction of the rexis. Now it's going outwards. So at this stage, you need to stop. Again, see in slow motion is now again you need to stop here, put some OVD. And go from another side port so that you can grasp the leading edge of the capsular rexis nicely and get it on the right track. So you need to have these rexis forceps, micro forceps, which goes through side port incision. So again, just pulling it in the center, get the rexis on the right track. So I'm just pulling it towards the center. Now, this is an intumescent cataract. We all know that they have a strong tendency that rexis may go outwards. So you saw that jerky movement of this. This happens sometimes in topical anesthesia, that patient suddenly moves his eyes and see, I was trying to debulk the capsular bag. And in that process, suddenly there was a jerk and I was trying to debulk the capsular bag, and because of this movement, the rexis has now this has irregular tears like this. So here you should always go and give a relaxing cut there. And once you give this cut, try to incorporate these irregular curved tear into the rexis margin. So go ahead and put high molecular weight OVD, go from side port, and again I'm enlarging the rexis to proper size there. So in the end, we have a perfect size of capsular rexis. Again, here again, because of the movement, the rexis is trying to go outwards. So here again, I give a nick here. And complete capsule, making a small capsular rexis. Now see again what happens when I'm trying to debulk. I'm debulking from this side, going from another port here. So when I'm these things happens when these capsules are friable, they are fragile. So and because of little movement in topical anesthesia, these kind of things can happen. But you need to be careful that you are able to salvage them. So here I'm trying to convert from here, but I realize that it's better to give a relaxing cut here and then try to finish capsular rexis, because this is, so again I give a cut on this side and trying to take this into the rexis margin. So again, holding it and completing the capsular rexis. So in the end, you have a good overlap of the IOL optic all around, but it's little more this side. So you can always go and secondarily enlarge the capsular rexis. So just last case, what I want to show here is this is the case in which the rexis had gone. There's an Argentinian flag you can see here. So here, what you're going to do is you're going to give a cut here and try to make the rexis in the remaining portion, which is there. So I give a cut there and use micro forceps to make capsular rexis, so it becomes like a keyhole. So now the question is to do phaco in bag or outside the bag. I prefer to do it in the bag, maintaining closed chamber. So this is and here I'm again maintaining closed chamber, putting OVD before I come out and doing irrigation aspiration. You can see the flutter sign there. Dr. Rohit Prakash has described this. So you know that there's not a wraparound tear. So here even this is a hydroimplantation. So lens goes in capsular bag and there's a little overlap is more this side. So I go ahead and maintain closed chamber and use a scissor to give a snip and enlarge rexis to perfect size and hydro stitch incision before you come out with your irrigation cannula, and this completes the case.
Which he highlighted was, visibility, which Chitra also talked about. If you can see better, you can manage the case better. If given an option, I'll not hesitate to stain the capsule again so that things are more visible. And the hooks is a very good idea in those cases also.
Tamil, can you take the next question?
Yes, ma'am. To Dr. Harshul, one other cause for rexis extension is sometimes we see this anterior insertion of zonules. How would you handle such cases? What is your tip?
So what I felt is that anterior insertion, you need to be little careful, but still if you are careful enough and your forces are towards center, you can easily get away through anterior insertion zonules. Otherwise, you can always cut through also these zonules if you want. Otherwise, as such, they don't cause any problem. If you try to make it with cystitome, of course, you'll have peripheral, centrifugal pressure, which is trying to take it outwards. But if you are using, so one thing is always use forceps. Wherever you have a white mature cataract, anti-insertion zonules, wherever you want good control, forceps is the key. You can
Yes, sir.
always direct the tear wherever you want.
Yes. Dr. Kiranjit, sir?
Yeah, there is a very important point I want to tell about this swollen cataract, in which cases we get a Argentinian flag, is that we make a primary rexis in the center, thinking that we are very much far away from the zonules and equator, but actually we are close to the zonules and the equator, because the pressure in the central part is much more than in the mid periphery. So it makes sense to make a primary rexis in the mid periphery, because while we are making a primary rexis in the mid periphery, the nucleus complex is held back uh, by the central part of the anterior capsule that holds it back. It is like a volcano. If you touch the center and the nucleus comes forwards by a fraction of a millimeter micron, it will split open the anterior capsule. But if you are making the rexes in the mid periphery, the nucleus will not move. And by making a CCC primary rexis in the mid periphery, you can aspirate you can do that dry aspiration from the sub-incisional area and all the quadrants. And after you have done all those things, you can give two nicks in the smaller rexes, and you can make a very big rexis, and you can avoid Argentinian flag in every case. So, and while we are doing it close to the zonules, we are actually far away from the zonules. It is just the opposite.
Yes, yes. So many interesting points for us to mull on. Harshul, that was an amazing talk.
Thank you.